Assalamu alaikum. Welcome and everyone on board. We will continue our discussion from where we left yesterday. Uh, the first question today is 41 years old man has been invasively mechanically ventilated for 3 days due to pancreatitis. Okay, so just for a revision, that pancreatitis is one of the condition which is a precursor for sepsis, for ARDS, and actually in some other condition, if like there is any trauma, there is excessive blood transfusion, and many condition, it's pancreas is very sensitive. Even for example, if there is a stone in the biliary tree, it can lead to pancreatitis. There are so many things which are correlated, and vice versa. Pancreatitis can lead to sepsis, ARDS, and a number of condition can lead to pancreatitis. So this is just for revision, and it is exam point of view. Pancreatitis is one of the question in which, in one question, they ask so many aspects of ICU, so many aspects of acute care. So there are concerns related to sepsis, very severe pain, hemodynamic instability. Even patient can go in septic shock. So this is some background information you should have about pancreatitis. Okay. So what happened? He develops pyrexia, an increase in oxygen requirement. So it means that PF ratio is changing. Each patient has fever, so this is a sign of inflammation, and he is noted to have new left lower zone infiltrates on chest X-ray. So this is acute in onset, and there is fever, there is an increase of oxygen requirement and infiltrate. So this is development of ARDS. So the question is, in this particular question, they are asking about organism. So E. coli is gram negative. Methicillin sensitive. Staphylococcus aureus, it's non-positive. This is also gram negative. Let's see what is vancomycin is resistant enterococci. So because this is a purely ICU based question, and you should know the basics of antibiotic therapy, like what is gram positive, what is gram negative, and what is specific sensitive or resistant bacteria. And like if, for example, if there is penicillin or cephalosporin sensitivity, what alternative antibiotics you need to give, what are basically broad spectrum gram positive, what are for anaerobes. So this is just basics of antibiotics you should know, because this is totally a question on that thing. So it's VAP, and as we know that with reference to VAP, the questions which they ask is what is the diagnostic criteria, what is VAP with the bugs which are related to early onset, which are the organisms which are related to late onset. So here it's VAP defined as tracheobronchitis or pneumonia occurring more than 48 hours after initiation of mechanical ventilation. This definition relies on a high index of suspicion with confirmation based on clinical, radiological, and microbiological evidence. So recent, this is because on guideline based, where may not require a positive microbiological diagnosis. CPIS, Johans criteria, there are a number of. And remember one thing, there is also correlation between ventilator associated pneumonia and ARDS. They are also coming together at number of times. Like VAP can lead to ARDS, and ARDS can further lead to ventilator associated pneumonia. So these are also correlated. Then all of them, they can lead to sepsis. So then sepsis lead to multi-organ failure. So they are quite closely related to each other. One will invite the other. Okay. So to the timing of the infection, onset the onset is early, so less than 5 days. So bacteria are methicillin sensitive, Staphylococcus aureus, Haemophilus, and the most common bacteria In late onset is aerobic gram negative, just like Klebsiella, Pseudomonas, Enterobacter, Acinetobacter. So these are, you should just, when you are reading these questions, you can just make your own key about antibiotics. As I told you, because unfortunately we are not doing ICU in Saudi Arabia. So at times we have limited revision. So I have not done in ICU since last 10, 11 years. So whatever knowledge I have is on the background knowledge. So value of, then with reference to uh, the diagnosis of VAP, the most sensitive is specimen brushing, and bronchoalveolar lavage is relatively less sensitive, and sputum culture is even lesser sensitive. So if you have protective specimen brushing, it means you just need very few colonies for the diagnosis. And if you have sputum culture, it should have more colonies. So this is just another few points about the diagnosis. Okay. And whenever there is ventilator associated pneumonia, there are a lot of things which are for prevention. And with reference, so you see, they have just a revision, quick revision about that bundles as well, that elevation and supraglottic suction, okay, daily sedation level, oral hygiene, supraglottic aspiration, as I told you, tracheal cuff pressures measured 4 hourly and maintained 20 to 30, stress ulcer prophylaxis. There is a whole of, I will just show you quickly, and then you can review. Like I have told you the main points which you should be knowing about this. So you see, we will go to ICU, and here you will find articles on this topic. Uh, like these are for VAP, okay, and the same thing which we were discussing. Okay, so risk factors, pathophysiology, prevention, the set bundles, okay, and diagnostic criteria as they were mentioning here. This was the CPIS score which was coming in this MCQ. So you can have a look here, scoring systems, okay, then treatment. So this is with reference to VAP. We recently discussed VAP in our uh, quick revision series as well. And so this is about ARDS. Okay. Uh, Here, if you come here, you will here find in the, these are actually topic wise. Just a second here. So this is about pancreatitis. So here you can see about the criteria, the clinical picture. Uh, Usually it's a clinical diagnosis. Some enzymes are raised, amylase, lipase, okay. And then there is a specific criteria, Renson's criteria, you see. So I'm just giving you a hint about it. So this is the Renson criteria, okay. This is Glasgow system. Uh, and this is how, what is the same significance which we discussed, that whenever you are reading MCQ, you just have to scroll your mind. So in this one MCQ, you can revise VAP, just quick revisions, because whenever they will ask certain question, they are right now they are asking about the bacteria. Okay. In other question, they may be asking about diagnostic criteria. Other question, they are asking about prevention. So if you keep on revising the things, uh, it becomes very easy, and your knowledge will increase gradually. Okay. Okay. So now the next question is a 32-year-old primary gravida with BMI of 55. So it's a class 3 obesity, morbidly obese. It is 10 p.m. She is currently 7 centimeter dilated and requesting an epidural. The baby is in the occiput posterior position. Of course, this is not our domain usually, but I think it's you are unable to palpate her spinous processes. On your third attempt, with difficulty, you perform a lumbar epidural and accidentally cause a dural tap. So just a few quick revision points that how you can improve your epidural in these scenario. So ultrasound can guide you that you can just quickly see the where is the midline, what level you are at right that moment, and how much is the distance from the skin to the space, where is midline, and which level you are in. So three information you can get from a quick ultrasound. Then you can mark and you can perform. So because during this stage, when patient has active labor, patient is almost 7 centimeter dilated, epidural pressure is increased. Okay. So another information you should revise how much is the UL epidural pressure and how much it increases during the labor. I don't remember the exact number. You can just have a look on this point as well. I think uh, usually it is negative, and even with active labor, it can go very high. So if there is more epidural pressure, there are more chances of dural puncture. Even the epidural space become narrow during the pregnancy usually, and especially in active labor, it it can become even further uh, create problem. So there are predisposition to dural tap. So this question is on this point that what will you do immediately? Okay. So what is the best line of management in this situation? Repeat your attempt at an adjacent lumbar level and use a smaller test dose. Request help from a colleague to attempt the epidural. Use ultrasound to help locate the depth of epidural space before re-attempting. Abandon your attempt and shoot a remifentanil PCA. Sit a spinal catheter, inform midwife, and perform subsequent top-ups. Actually, in this scenario, like a number of things are option. Let's see what is there in the key in this question. Because in our setups, I have never done spinal catheter, but usually what option you have, because if you patient is on active labor, so if you will try to reattempt, the chances of another dural puncture is there, and actually you don't have much time. So that is the reason in which you have to use the depth and everything. This is also will take time in this situation when you already have done a dural tap. So in this situation, the one option usually is that we can reattempt or we can cite a final catheter. So in that scenario, on the basis of this thing, they have uh, you will put a spinal catheter, and you should be knowing usually the doses in epidural and spinal, they are usually 10 times. So it is 10 times less in spinal. So that's how it goes. So accidental dural puncture is a well-known complication of epidural, being said to occur in 0.2 to 4% of cases. Parturients are at risk due to difficulty in positioning, being moving targets. In this case, there is added that patient has very high BMI. Okay. And this case, typical of pressurized situation on labor ward, and the clinical setting must be taken into account when deciding how to manage the dural puncture. Repeating the attempt is potential option, but it's not the best line of management. In this scenario, attempting again can have another dural puncture. The chance of a colleague being available to assist at this time is slim. Like this is again and the scenario they have mentioned, as opposed to during a day shift. In the morning, there will be more manpower. Although this is a possibility, a colleague may also find this epidural difficult to perform, and there may be significant delay before they can attempt to attend to help. Ultrasound can help to locate the depth, but even with optimum condition, this will be difficult in a lady of this size, especially if you are unfamiliar with this technique. Finding the ultrasound machine and correct probe may also prove challenging in this. Remifentanil PCA is a potential alternative, but in this situation, the lady has a high risk of needing further intervention due to the position of the baby. Therefore, a spinal catheter is the best option reduce the risk of neurological damage. No more than 3 centimeters left inside the subarachnoid space. The catheter must be clearly labeled as intrathecal, and both the midwife and mother must be informed. Top-ups must be given only by the anesthetist. Subjective regime may be 2.5 ml of low dose, 0.1 percent. So, like, usually we can go up to 20 ml per hour. Okay. And here they are making, as I was telling you. Mr. AHN, please don't write on the screen. So roughly, as I has mentioned, that usually the the spinal dose is usually 10 times less than the epidural dose. That's what they are doing. Uh, of, uh, in our setup, of course, levobupican is not available. So bupivacaine with 2 mics per kg, so 2 mics per ml of fentanyl. This is the usual standard we are using in the um, this one epidural. So here I have a doubt. Again, you see, as I told you a number of times, these books have a number of times they have mistakes, and some things which you should they should mention here about this one uh, preservative free. So it should be not be the same one which is there which we use in our like other scenarios, places. So this should be mentioned and should be in your mind that whatever they are using in intrathecal, it should be preservative free. This can also be used if the patient goes to need an operative intervention. So there is also some evidence that introducing a spinal catheter may reduce the incidence of PDPH. So this is another thing because this patient will have uh, uh, more chances of dural PDPH. So, like in this question, the thing which are you are giving the revision, first of all, how to avoid dual puncture, what options you have to improve your technique, what will be the challenges in obese patient, what are the challenges in epidural in a pregnant patient, what are differences in pressures in non-pregnant and pregnant, and what are the alternative options of like another option just comes to my mind. It's not written here. We can have a like a saddle, low dose saddle if it is even progressing towards this second stage. If it is even more dilated, because this is 7 centimeter, so it's still maybe it will. I'm not sure whether they put it as a primary. Okay, so primary may take more. This another point which they have written is I have no idea about this occiput posterior position. So if you can have some points about this, usually in our exams, usually they don't put your common position is breech. We know all of know. So maybe you can have some information about different positions. So these are the maximum things which they you can extract from this question. Then you can also what will be the options of TDPH management, what will you do in this case? Another point which I just remember, sorry, did not mention, that epidurals should be done in lateral position usually, and this is a message for the junior residents also, that ideally if you can learn to do regional anesthesia, central neuroaxial block in lateral position, it's always good. But of course we are not trained, and it sometimes become difficult if you are immediately doing it in lateral position in such scenario. But actually in lateral position there are less chances of PDPH. Anyways, another thing is doing it in paramedian. So paramedian also has less chances of PDPH, less chances of backache. So this is another point. But again, you should be knowing that they have not written here. But in this scenario, maybe you need long needle, not the normal 10 centimeter. Maybe you need the even longer epidural or spinal needle. Just generally for central neuraxial block, you might need to have longer needles. Okay, and especially if you are doing paramedian, maybe you need 1 to 2 to 3 centimeter more distance because you are going in an angle. Okay. So, but because in when you are going paramedian, actually the structures which are not in the midline, sorry, which are there in the midline are not there. One of them is supraspinous ligament and one is interspinous ligament. So you bypass these ligaments, okay? And because the healing of ligaments is slower than healing of muscles. So when you are going paramedian, you bypass the ligaments. So theoretically, this is the reason of relatively less backache. Okay. So this is the rationale. The reason for less chances of PDPH, I don't know exactly. But the data suggests that I think it is relatively less chances. But when you are going lateral, because the nerves are coming, so there will be more chances of paresthesia, which we can encounter in midline as well. But if you are doing paramedian, you have to inform the patient that you may feel a current-like sensation. So there are more chances of paresthesia. Okay. So, and another thing, vessels are coming, so there may be more chances of the bloody tap. Usually, even I'm not specifying for this MCQ only. I'm just telling you the points which you should be knowing about paramedian. So paramedian technique, I love it. I uh, usually a number of time I do paramedian. Okay. Spinal. Epidural, of course, and it needs more practice. Okay. So these are some important points. And also you can revise about obesity. So BMI of 55, you just think what are the things which can be there. uh, Initially, when you are preparing for the exam, maybe you should brainstorm yourself in a more way. And even if you are doing one MCQ, just uh, do more and more brain exercise. So, okay, in obese patient, there may be chances of difficult airway, there may be chances of OSA. If it's a prolonged one, patient can have coexistence of cardiovascular problems and patient there are more chances of metabolic problems, diabetes mellitus, hypertension, and then the whole circle of cor pulmonale. Okay. So you can have difficult in monitoring, you can have difficult in IV lines, you can have difficulty in whose patient transfer, you need specific trolleys and specific beds. Okay. You can have problem in the mass ventilation, so you need like ramp position. um, like, so these are the things you can just revise in your mind when you are thinking about obesity. So these are the thing. And another thing, dosing of medications. Okay. So the medications usually, if you forget, usually the medications which we use in anesthesia, usually it is on lean body weight. So lean body weight is one concept, is ideal body weight, one concept is lean body weight. Okay. So lean body weight is ideal body weight is relatively low. Okay. So because it's height in centimeter minus 100 in males and 105 in females. Okay. So usually 15 to 20% of the weight of this one plus ideal body weight is the lean body weight, and it is for the body fat. And remember this thing that usually we take maximum of 70 kg lean body weight for female and maximum of 100 kg body weight, lean body weight for males. So this is the concept you should be remembering even practically, that the usual medication, yes, of course, you will find even further differentiation that which you are taking for total body weight. Initial dose for maybe propofol you need for total body weight, or sometimes succinylcholine you need with total body weight. But if you forget, usual medications are on lean body weight. Okay. So these are few words about it. Uh, just a second, I will just show you. For this topic, you will find here in endo, you will go endo, and then you will, sorry, here for obesity. Okay. So you will find here association with OSA, the drug dosing, like this what I was telling you. So lean body weight up to 100 kg for males and 70 kgs for female. and actual body weight, as I told you, for succinylcholine, and I maybe the some of the other medication, but usually the common things are this one. This is very difficult formula, but it is ideal body weight plus 15 to 20% of ideal body weight as a body fat. So this point, and for this OSA, you need to you can have a lot of scoring systems. So one of them is this stop bang and this Berlin questionnaire. So you can have points related to obesity here. Yes, this is another very important perioperative management of a obese surgical patient. So especially if you are appearing for British exams, you can have questions based on the guidelines. Okay. So if you have this document, you don't need to be worried. This is the most important thing, the recommendations. Okay. So if you have the recommendation, you can cover, and then you can have some definitions. Okay. So uh, you can have a look on these guidelines, because a number of questions, some people ask me, you are preparing for FCAI, so what should we do? So actually these are the different thing, because maybe in our country, maybe in our system, such questions are not made, which are made specifically on guidelines. But if you are going to this part of world, you need to uh, prepare such guidelines, that one of them is AAGBI, one of them is NICE, there are NAP, National Audit Project, findings of NAP, they ask in a number of questions. Then, with reference to gynae ops, they ask on the basis of CMAC, Confidential Inquiry into Maternal and Child Health. Okay, so these are just sideways you can have. Uh, this is another important thing, that is what is ramp position. So this is the ramp position in which you elevate. Actually, there is a specific Oxford pillow which is designed in this direction with a little hair. So your aim is to elevate the external auditory matrix at the level of sternal angle. Okay. So this is called ramp position, rapid airway management position. So you make a ramp and you make rapid airway management position. Okay. So for many years, I used to think that it is only the ramp, the virtual ramp. So, okay, let's move. Okay. So you are fast bleeped. The people who are not in Saudi Arabia or in some part, they don't know what is bleep. Actually, bleep is uh, you can say messages come inside the hospital like that. So this is bleep. It will be start buzzing. And when you are on-call duty, this is one of the worst sound you can have. So, anyways, so to the emergency department, where a 22-year-old woman, 28 by 40, like 28 weeks, is with a history of seizure for past 45 minutes. So this is bringing the concept of this, what maybe this is uh, uh, eclampsia. Okay. A wedge is placed under the right side of the patient, and large bore intravenous access has been secured. Her blood pressure is 180 by 110, heart rate is 154, respiratory rate is 24, and ABG is with pH of 7.2. Obstetric registrar is present and suspect this patient. This is an eclectic fit. 4 gram magnesium sulfate has been given over 5 minutes. Antihypertensive medication has been started. The patient is still fitting. What should the next stage of management be? So this is a wonderful scenario for eclampsia. Remember one thing, that in this scenario, you have three goals. You have to control the blood pressure, you have to control and prevent further fits, and you will have to deliver the baby. These are the three things. This is one point. If the patient is constantly fitting, your approach will be airway breathing circulation. So that's another. Patient can aspirate. So you patient can have neurological injury. If you are trying to intubate the patient in such scenario, patient blood pressure can go even further crazy, and you can have some cardiovascular or neurological incidents, like patient can have CV. So these are important things. About few points about magnesium sulfate, that whenever you are starting magnesium, what you should need to know, that magnesium levels are maintained by in a very tight way, mainly by intercompartmental shift, but usually through the kidneys. So there is a misconcept that magnesium will cause renal failure, because they are saying whenever you are giving magnesium therapy, you have to monitor the urine output. But actually, magnesium sulfate cannot do, magnesium does not cause renal damage. Renal damage can cause, if renal blood flow is hampered and if urine output is not there, the magnesium level can become toxic. This so magnesium does not do renal failure. Renal failure, or if there is acute kidney injury, if there is no urine output, so this is a dangerous thing, and magnesium level can suddenly become toxic, and it can lead to depressed uh, tendon reflexes in first stage, then stage 2 of respiratory paralysis, and then stage 3 of cardiac arrest. So this you should be very carefully thinking about it, that magnesium does not do any renal damage. This is one point. Then second point is that magnesium levels you will find in different values. So please remember one thing, that SI unit of ions is millimole per liter. Okay, millimole per liter. But you will find magnesium levels millimole, magnesium level in milliequivalent, and magnesium level in milligram per dl. In our Pakistan, major or some part of the world, it's coming in milligram per dl. So you should be knowing that millimole level will be, for example, if 1, so milliequivalent will be 2, and milligram per dl will be 4. This is a rough, there is maybe a little bit of difference, but you should be knowing in one level, in one value. Okay, so that you don't forget, and actually you can easily mix. So make sure that you know what is the exact unit they are presenting. Okay, so because for example you see 1 and it is written in millimole, so it's significant. If you forget that it is millimole or milliequivalent or milligram, then you can do a serious mistake in your identification of the question. So this is another important point, that you should be knowing which unit you are taking. So renal involvement I have told you. So how can you monitor magnesium levels? You will monitor urine output, you will monitor the deep tendon reflexes, you will monitor the respiratory through ABGs, or you can visualize the respiratory movement, and you can have ECG. So if you are giving at a higher dose, like they have given 4 gram, and then they will start the infusion as well. So in this scenario, you should be knowing that how will you monitor. So these are very important high yield points which you should know, and it can come in the MCQ. Of course, you need to tell in the Viva as well, but that's another request. Since you are listening to me, remember one thing, please, please come out of this uh, terrible approach that, sir, let us pass the written first, then we will prepare for Viva. There is no difference between written and Viva. If you prepare yourself in a way that on the day of your written, you have such a preparation that the same day they take your Viva and you don't fail in the Viva, that day you will not fail in written. I repeat that if your preparation in that level, that on the day when you are appearing in the written exam, the same day they take your Viva and you don't fail in the Viva, I guarantee you that day you will not fail in your written exam. So please don't differentiate between written and Viva. Prepare yourself in a way that you are covering both the aspects together, because sometimes there is very little gap between written and Viva. So you will be in trouble. You will not be able to pass. Even if you pass the written, then your misery will not finish, and you will have to wait for 6 months more for the Viva. So if you don't prepare yourself in that way, and there will be chance that you don't even clear your written. So please, this is a request to you. Then at the same time, I will request you another thing, that try to, because now we are in 2025, and our mode of studying and mode of anticipation should be different. traditionally people used to make notes. Of course, there is no replacement for it if you write by your hands, but now we are in era of smartphones. So I will highly suggest you that whatever you are reading, at the end you make audio notes. Okay, and then you can note, like whatever I have read here, you open a book, you read something, you make an audio note that I read this MCQ, I read this topic, and these are 5 6 important points. This is the criteria, this is the early onset, this one, this, then this, whatever information you think that it is reproducible, you record in your own voice and label it and put it in your mobile. You can put it on the Google Drive, save it carefully. Okay, and then this may be your revision as well. So after 5 6 days, you are in the hospital or you are in a place where you cannot read the book, but you can just put headphones and you can listen to all the recordings, 50 recordings or 100 recordings you had done. Just play, plug and play, listen to it. This will be your revision. So this is a very good way for all of you to practice and to revise. So this is another suggestion I have given to you. Okay, so these are the things which you should be considering. And this, coming back to this scenario, the other thing which will be that because the heart rate is also high, the blood pressure is also high. Okay, because usually the options for controlling the blood pressure are, for example, labetalol or hydralazine. In this scenario, labetalol will be a better choice because actually it's also first line drug usually. But in this scenario, it will be even more helpful because it is the patient has very high heart rate. So labetalol will be the drug of choice. Of course, they are asking in some other way. Okay, so but you should be knowing about what will be the drug of choice with reference to antihypertensive. Then another thing you have to do is the discussion with the obstetrician, and you will try to have the maturation of the lungs with this steroids. You will try to control the things, but if the things does not go in right direction, priority is given to the mother. Okay, because 28 weeks baby can survive. So if you are not able to control the situation, then you might need to go for emergency cesarean section. This is just, but even if you are asking, if you are explaining in the viva, you always have to say, because you are not the one to decide to do the cesarean section. You will say we will have a multidisciplinary team discussion with obstetrician, neonatologist, and ICU, because this patient go to post-operative ICU. The baby will go, most probably can need the premature baby. So all the care related to prematurity, neonatal ICU, neonatologist should be on board. You will try to prolong the pregnancy as much as possible. But in this scenario, according to the risk versus benefit, I think you will need to go proceed with the cesarean section or delivery of the baby in whatever way. Okay, so this is another point you should, because till the time you don't deliver the baby, patient will have still chances of hypertension and fits. So this is the background information which you should have about this whole topic. Okay, so coming back to,
ازاي نقفل الزوم ده؟
sorry. Okay,
مش
so
عارف. صورتك.
this is this is just a background of for these things. So what you need to do: secure airway with endotracheal tube and perform emergency cesarean section in ED. This is one option. Commence magnesium sulfate infusion 1 gram per hour. Secure airway with ETT and perform cesarean section in ED. Commence magnesium sulfate infusion at 1 gram per hour. Give a further 2 gram secure airway and continue supportive management. Give a further 2 gram bolus. If no response, administered phenytoin. Magnesium sulfate 1 gram per hour. Give a further magnesium sulfate. Secure endotracheal tube. I don't know what is the answer in this scenario, but let's think that they are saying for supportive management. I don't think so. Let's see what will be the answer. Okay, so the answer which I was saying no is the answer. Okay. Uh, Actually, that's the problem, that how they create this in this scenario, on which basis they are taking this, because uh, if you just scroll here, they are in this option, there is no link of magnesium. So this is That's not a good answer. Here, they are saying 1 gram per hour and then endotracheal tube or cesarean section. This is in second. Here, the which is the correct one is, uh, I think they are trying to give more time as practically we do. That's why this answer here. Let's see what is the explanation. So preeclampsia is one of causes of maternal death, and since it is well managed, it is not often that patient present with uh, eclamptic seizure. The MACPI trial, I don't know what is it, demonstrated that magnesium sulfate significantly reduces the risk of eclampsia, and this is standard management in these cases. The initial dose is 4 gram over 5 to 10 minutes, followed by an infusion of 1 gram per hour for 24 hours postpartum even. Or if you have fits, I think continue for further 24 hours. If I'm not wrong, it's like that. Any subsequent seizure may be treated with a further bolus of 2 gram. Phenytoin and diazepam have no place in the management of eclampsia. Every effort should be made to stabilize the mother, correct hypoxia, control blood pressure, and stop seizure before undertaking a cesarean section, as this is a risky procedure to undertake while mother is unstable. Also, the emergency department is dirty environment, therefore the risk of post-operative infection is high. There is unlikely to be diathermy available, and the patient may bleed significantly, which is risk due to disorders of coagulation that can occur in eclampsia. Furthermore, the baby is only 28 and course of steroid treatment would help lung maturation. If delivery were expected to be undertaken, it may be better for the baby to undergo in utero recovery from hypoxia and hypercarbia. If the mother were to arrest in the emergency department, then so I think that's the reason for this is that if they had given any hint of fetal distress, then emergency cesarean will come. Okay. So that's why emergency cesarean. Okay. Here they are saying that phenytoin. So phenytoin is not considered. And here also uh, the in emergency. So the reason, the trick in this question is that unless it is, they will proceed for cesarean section with some planning. Okay. So as I was mentioning in my discussion that what are the goals in this patient. Okay. So that's how you, the one point I forget about magnesium sulfate is that magnesium sulfate will enhance the activity of neuromuscular blockers. So if you are using neuromuscular blockers, so the you have to carefully monitor the effect, and you might need to reduce the dosage because it can prolong. And another answer you should be thinking or you should be telling in when you are explaining this, that in addition to standard 1 and standard 2 monitoring, extra monitoring you will be needing in this scenario will be urine output with reference to magnesium sulfate and neuromuscular stimulation with reference to use of magnesium. Okay. So these are extra monitoring you need to do uh, in this scenario. Okay. Then another extra monitoring you need to have is intra-arterial blood pressure monitoring. So with if you think about monitoring with reference to this case, these are the things which should be knowing. Intra-arterial blood pressure monitoring you might need. Okay. And then, as I told you, urine output, neuromuscular stimulation. You can say if the patient further deteriorate, you might need to have with reference to if the patient, if they give a scenario of bleeding, then the tag thromboelastography can come. If they are saying about volume overload, then this cardiac output monitoring can come into the consideration. So that's how uh, you will proceed. Okay. Okay. So a 5-day-old boy presents to a local emergency department with a 2-day history of increasing respiratory distress. Okay. Respiratory distress in 5-day-old. So just after delivery. He is lethargic with a heart rate of 184, respiratory rate of 68. So he is tachycardic, tachypneic, blood pressure of 60 by 30. So you should revise what are the normal blood pressure readings with reference to the age. Okay, capillary relief will time of 6 seconds, so it's more. So there are signs of respiratory insufficiency as well as cardiac insufficiency, like poor circulation. Okay, SpO2 is 96% and unrecordable from the other limb. So do you know this right hand? This is with reference to preductal. Okay, because the right brachiocephalic trunk will come before the origin of ductus arteriosus. Okay, so in such cases, if you have uh, uh, persistent fetal circulation and you want to monitor either the correct ABGs, or if you want to monitor the blood pressure, you need to have preductal, that will be right radial. Okay, so here they are saying that SpO2 96% on air on the right hand, but unrecordable from the other limbs. So his axillary temperature is 36, but his extremes are mortal and feel cool to touch. The chest sounds clear and the heart sounds seem normal with weakly palpable femoral pulses. He was given a bolus of 10 ml per kg and broad spectrum antibiotic. A rapid sequence induction was performed and the patient intubated and ventilated. So, what to do? So, like, because they have weak femoral pulses. Okay. So, let's see what are the options. Uh, okay. So, actually, prostaglandin E2 is to, if the patient has this coarctation of aorta, they need to have the persistence of this PDA. Okay, so for this one will be to keep the PDA persistent. Okay, so that's they have said in this scenario. Let's read out because it is a difficult. Okay, so stabilization of critically ill neonate, as with all pediatric patients, should prioritize securing the airway, then establishing breathing and maintaining adequate circulation. Endotracheal intubation and fluid resuscitation are usually required in critically ill neonates, and these procedures, if indicated, should not be delayed while waiting for diagnostic evaluation. Establishing optimal ventilation oxygenation is often sufficient to improve both respiratory and cardiac insufficiency. However, continued IV fluids and resuscitation may be required in gravely ill neonate. Actually, what they are saying that you need to correct the volume status, because initially you see an initial bolus of 10 ml per kg of isotonic fluid should be given. The terrible PEDS solution which we use is a history. It's a killing solution. This 0.18% normal saline with 5% dextrose. So never use it. There is no indication for it. And okay. Sepsis is one of the most common cause of critical illness in the neonate, and prompt empirical treatment with antibiotics is almost always indicated. If the history and physical examination suggest a possible cardiac diagnosis, a continuous infusion of prostaglandin E2 should be promptly initiated and pediatric cardiology consulted. Coarctation of aorta is a congenital narrowing of the descending thoracic aorta at or near the connection of ductus arteriosus. Because if you just recall the fetal circulation in fetus, because the lungs are not mature, so when the pulmonary artery, the blood is coming out of the right lung, immediately it is connected from the pulmonary aorta, sorry, pulmonary trunk to the aorta through this ductus arteriosus. Okay, and then it is going to the lower half of the body before. Uh, just let me just just quickly revise this concept as well, because we talked about ductus arteriosus. Just give me a second. Actually, what happens here? you see that, for example, this is consider this is aorta, and pardon me for my bad drawing, but for example, this is pulmonary trunk is coming out, okay, and this is aorta. So here, this is uh, ductus arteriosus, and before this is originated, the right brachiocephalic is coming out. So this is going to the right side. Okay, so this is ductus arteriosus. So actually, before, because this is bad blood, this is blue blood. I'm sorry, just because I need with a bad drawing creating more bad. If you just recall the right atrium, blood is coming, which is oxygenated blood coming from the this through the this mother side, the placental side, and then it is mixing up with the blood coming from the this from the superior vena cava, which is deoxygenated blood coming, and it is mixing in right atrium. Okay, and usually here it is going from the right atrium to the right ventricle through the right atrium to the left atrium through the foramen ovale. Actually, I have messed up with my concept. Just let me. Just a second. Actually, what I have, I'm confused in explaining, but usually there will be two different sort of blood. The blood which is coming from the this from the liver side, it will have more oxygenation, and when it is mixing up with the, I'm really sorry because this just washed out of my mind. So I will, I need to review this before explaining to you. So pardon me for this fetal circulation. I will, inshallah, tomorrow I will explain to you. Okay. So this is because this sometimes some concept just wash out of my mind. I don't want to tell you in the wrong way. So what we will do, I will stop here and we will continue from the same position here. So the concept of this fetal circulation from here, we will continue tomorrow. So pardon me for this inconvenience because I don't want to give you a wrong concept. I need to review it. Just, you see, sub just slipped out of my mind at the moment. So pardon me for that. We will continue from here. Okay. Bye bye.